Grand Rounds. It's my pleasure to introduce today's speaker, Dr. Robert Myette. Rob is a second-year fellow in the training program in nephrology here at CHEO and University of Ottawa. He enjoys his clinical work and has a strong commitment to teaching. He loves biking around Ottawa, but really, and perhaps relevant to this talk, I'm sure that he will get into it a little bit. He has a very strong interest in research and a particular interest in podocyte biology, and will go on to further research training upon completion of his fellowship here. And we're happy as a department to support Rob as he continues on that path. Today, he's going to address the issue of the Leaky Glomerulus Pediatric Nephrotic Syndrome. So welcome, Rob.
Thank you very much. I'll just get my screen shared. Everybody can see this okay? Probably yes. So Dr. Duffy, thank you very much for the introduction, and to the department for having me for today's presentation. And thank you all for joining and for your attention. And indeed, today I'll talk about the leaky glomerulus, more specifically Pediatric Nephrotic Syndrome, and kind of where we are at today, broadly speaking, and where we're going to be going, hopefully, in the future. So the objectives for today's talk will be to just broadly review childhood nephrotic syndrome with a focus on idiopathic nephrotic syndrome, to highlight some current and emerging therapies, and to review new research in pediatric nephrotic syndrome. So if anybody who's connected to the call has been with me when I've done a teaching session on nephrotic syndrome, they'll know I appreciate going through things in a stepwise process. So nephrotic syndrome can be characterized initially by proteinuria with subsequent hypoalbuminemia and resultant edema. And we're going to build on this throughout the course of this talk. Before we get there, I want to do a very quick review of renal anatomy, just in case anybody has forgotten my favorite organ. So basically, looking at a pathology section of a kidney, we can see the different components. And I'd like us to zoom in. And here we can see the glomerulus, its associated tubule collecting duct. When we zoom in even further on a glomerulus, seen here, we can see we're starting to find a much more complex part of the kidney the closer we zoom in. And as we get into the 3D structure, we can see what looks almost like an octopus-like structure, which is the cell body of a glomerulus. And then these projections, which are foot processes. And in there, in interdigitating foot processes, we have slit diaphragms, which are responsible for filtration. This is a cross-section through of the podocyte once more, again, looking at the cell body and these foot processes attached to a glomerular capillary, which is paramount in the production of urine through filtration. And what I want you to take home today from this discussion is that nephrotic syndrome is a clinical presentation of a podocytopathy. Basically, when the foot processes become effaced for any particular reason, we have massive proteinuria, which results in the clinical phenotype of nephrotic syndrome. So how do these children present? Classically, they'll present with progressive edema, but what's important is in the community, at the CHEO emergency room and all the other hospitals across the world, these children commonly present with just very mild periorbital edema to start, and they're often misdiagnosed as having allergies. One clue is that the initial edema episode may often be preceded by infection, even a very mild upper respiratory tract infection. And it's not uncommon for us in our clinic to see children presenting in this way with quite massive edema. And they can range from being clinically stable with only mild dehydration to having a significant AKI as a result of their proteinuria and subsequent intravascular volume depletion. When we think about the etiologies, we can broadly categorize them in two separate ways. One is based on whether they are idiopathic or not, and a second based on their response to steroids, and that will come later in this presentation. When we think about idiopathic, again, I'm taking a generalization slightly here, but just to make it easier for this discussion, we can categorize the genetic forms, focal segmental glomerulosclerosis, and minimal change disease into the idiopathic nephrotic syndrome bundle. And the non-idiopathic, there's quite a significant number of conditions that can cause nephrotic syndrome that we'd have to consider if it wasn't a classic presentation, or if we needed to obtain a biopsy in a patient and determine that they had, for example, one of the more common nephritic conditions, whether they had membranous, sickle cell, and a variety of other causes, including infections and medications. For simplicity, I will be speaking only about idiopathic nephrotic syndrome today. Moving forward, genetic nephrotic syndrome, which fell into this category of idiopathic, can be summarized by looking at the number of genes and their resultant protein products that are present in a podocyte cell body, foot process, and slit diaphragm. And we're not going to spend much time going through all of these, but just to show you, to date, there are nearly 70 different genes that have been identified that may cause a genetic form of nephrotic syndrome, which has its own clinical phenotype and is outside the scope of this discussion. The second in our list going downwards was FSGS, or focal segmental glomerulosclerosis. Again, it will not be the topic of today's discussion, but it should be mentioned. And what's important is knowing that these children typically present, again, with nephrotic syndrome as the clinical phenotype, but on biopsy will have focal areas or segmental sclerosis. And evidenced here is actually a tip lesion, this glomerular tip lesion variant, but FSGS is most commonly characterized on biopsy with synechiae and segmental sclerosis. Importantly, and throughout this talk, we'll talk about the gene environment and its effect on human health. It's important to have a look at incidence and prevalence of FSGS lesions across the world. Data here in this box are expressed as a percentage of total kidney biopsies done from international registries. So we can see in Canada, we have about 0 to 10 FSGS lesions. Again, that's a broad spacing of percentages, but it's variable across the country. Whereas in the United States, just below us, we seem to have a lot more patients with FSGS lesions on biopsy. Next, we'll talk about minimal change disease, which is my favorite topic. And it is another one of the characterized as idiopathic nephrotic syndrome. And it has a very interesting pathophysiology in that it is not quite known what happens and why children present with minimal change disease. There are two leading causes of, or two leading theories, I should say, as to the pathomechanism of minimal change disease. The first being an immune-mediated process, and it's thought to be driven by T cells. And this was evidenced during measles epidemics in children who had minimal change disease who developed measles, which can deplete T cells. These patients would then end up in remission with their minimal change disease. A more recent development is looking at something called a CD80 ligand, which is involved in the binding of T cells and its upregulation or the inability to silence its signaling in the podocyte, which is thought to be possibly related to minimal change disease, although both of these are not fully characterized and fully understood. Secondly is this concept of what's called a soluble locally acting factor. So children with minimal change disease, it is thought that something is floating around in their bloodstream. We're not entirely sure where it's coming from or what is driving it, but it is causing the development of minimal change disease, as well as a propensity for relapse. And we're not quite sure what it is, but there are a couple important characters, although we're not sure based on the current literature whether these are going to pan out to be the elusive soluble locally acting factor. Again, when we take a look here at the map of the world and the incidence and prevalence of minimal change disease lesions, we can see in certain areas in the world, there are significant biopsies finding minimal change disease lesions. And when we look at ourselves here in North America, again, it's about 0 to 10. Again, these are expressed as percentages of total kidney biopsies from international registries. So again, I wanted to highlight the importance, I think, of the genetic factor associated with this, as well as it could be environmental in different areas of the world. What's important to keep in mind when we talk about minimal change disease is this graph, which is quite striking for me and shows that children between the ages of 1 and maybe around 15, we can go back as far as say 10, there's a very large percentage of them that present with a classic minimal change disease on biopsy. And that's in historic investigations, such that nowadays, when we have a child who's presenting with a clinical phenotype consistent with minimal change disease, falling into this age category, we often do not request a biopsy and start them on treatment because the overwhelming majority of them will be presenting with minimal change disease. I'm going to switch gears slightly and start talking a little bit about the investigations for idiopathic nephrotic syndrome. So we've looked at the genetic forms, we've looked at FSGS, and we've looked at minimal change disease. But when these children present and they're somewhat undifferentiated, as I just said on the previous slide, if they appear to be most in keeping with minimal change disease clinically, we do not have to perform a renal biopsy. But most children would undergo the workup as follows on the screen. I've highlighted a few that I find are very important for us to keep in mind. In any situation where you have a child who is swollen, we should check their urine in the appropriate clinical context to see if there's protein in their urine. We should do a serum albumin that will help us to actually diagnose nephrotic syndrome. And we look at cholesterol, which appears to be an innocent bystander in the whole process, but will be elevated in children with idiopathic nephrotic syndrome or nephrotic syndrome as a whole. It's also important for us in cases where it is less typical to think about complement and sending serum samples for complement. And then again, in the rarer cases, we'll have to obtain biopsy or do genetic testing. As we go through this talk, we'll also see there's the importance of checking kidney function because AKI is common in this population, particularly those who are hospitalized. So considering the previous slide, if we were to look at a urine study in a patient with nephrotic syndrome, we have a few options to diagnose them with nephrotic syndrome. I've bolded the one that I like best and I use most often in clinical practice because it allows for normalization to the patient's creatinine. But each of these is considered acceptable in the diagnosis of nephrotic syndrome, again, with accompanying hypoalbuminemia and edema. The treatment for idiopathic nephrotic syndrome, again, taking into consideration a typical presentation in the appropriate age range, we would start these patients on steroid therapy. And this is a very hot topic. Right now across Canada, there are a variety of centers looking at different approaches to treatment with steroids. The classic approach would be a very long 12-week course of steroids. And these children are exposed to very large cumulative steroid doses. They would have 6 weeks of steroids at 60 milligrams per meter squared per day, a maximum of 60 milligrams, and then 6 weeks of steroids at 40 milligrams every other day, with a maximum of 40 milligrams every other day. Now, when I started this discussion with you, we talked about categorization into idiopathic and non-idiopathic. And now I wanted to talk a little bit about how we can categorize nephrotic syndrome based on the response to steroids. However, it isn't as simple as just saying, yes, they do respond, or no, they do not respond. With nephrotic syndrome, classically, we would provide treatment in our hope that we would bring children into remission. Now, these children were not ever certain if they're going to remain in remission after a single course of steroids or if they're going to experience relapse. We don't quite have a good handle on why that happens. We do know there is a significant percentage of them that will relapse, and I will talk about that in the upcoming slides. When things start to get more challenging is when children progress from remission or infrequent relapse to becoming frequent relapsers, steroid dependent, or even steroid resistant. When we look at a large childhood cohort, this came out of Toronto, with nephrotic syndrome, there were 631 children. This is from 1993 to 2016. They found that the large majority of children on initial presentation had some degree of steroid sensitivity, or a large percentage, had steroid sensitivity at presentation. And only 42 of the 631 had steroid resistance up front. And now following these arrows, I'll stick with the steroid sensitive patients first. We can see that even though they were initially steroid sensitive, there was a significant proportion of them that went on to be frequently relapsing, infrequently relapsing, or obtained complete remission after the initial course. And the second thing that I think is important to highlight is those who were steroid resistant at presentation. If we follow this blue arrow across, we'll see some of them obtained complete remission after their initial course. Now you may say, well, what do you mean if they're steroid resistant? In this case, the authors took the liberty of saying their initial course would be a secondary immunosuppressant in the setting of steroid resistance. But taken together, what that means is they were able to drive the patient's disease into remission, into complete remission, in fact, after that initial course. And what's important here is looking at those patients who ended up with end-stage kidney disease. In a cohort of 631 patients, only 10 ended up with end-stage kidney disease, or approximately 2%. So who does respond to steroids? 93% of children respond to steroids, at least initially, and 85% of them will become disease-free during childhood. What this means basically is that they are either discharged from the clinic prior to their 18th birthday, or they've been discharged earlier than that, so during childhood, of course. Interestingly, 22% had no active disease following their first treatment. And again, keeping in mind that means either the steroid responders who were given a course of steroids, or steroid non-responders who subsequently went on to have a steroid-sparing immunotherapy. 30% of children receive only steroids as treatment. And again, I'll highlight this is Canadian data from a single center in Toronto. 31% would receive steroids plus a secondary therapy, and 17% will require 2 other therapies. Again, highlighting here that about 1 to 2% will have progressive kidney disease. So what are the secondary therapies? Again, as we walk our way through this presentation, we can see children will have steroids up front in almost all of cases. If they have steroid-sensitive disease or steroid-sensitive nephrotic syndrome and infrequent relapses, we are very confident that they will achieve long-term remission. If they go on to develop frequently relapsing or steroid-dependent nephrotic syndrome, we try our best to get them to a low-dose steroid regimen, but if they have significant relapses or steroid toxicity, we have to think about other medications as listed here. Now, although this paper came out in 2018, they list levemizole here, which is not commonly used. Cyclophosphamide has had a good effect in some single center studies. Upwards of 40% of children will have a very positive response to a course of cyclophosphamide. Tacrolimus or MMF, mycophenolate mofetil, are some of our second-line agents that are most commonly used at our center here at CHEO. And it's important going forward that these children who are placed on this medication, particularly tacrolimus, will obtain a biopsy from time to time, as there can be untoward effects from the medication on the kidney. And when all else seems to be failing, we often go to rituximab in an effort to drive children in their disease process into long-term remission. And it's interesting because when we initially were talking about the possible immune-driven pathophysiology of rituximab, it kind of makes sense. But what's interesting, in fact, is that rituximab was also shown to stabilize the actin cytoskeleton of podocytes. So it is not exactly clear whether it's its effect on the podocyte actin cytoskeleton or the effect on the immune system. Importantly, we like to spare the children exposure to these medications because they all have side effects. If we find that children are steroid resistant and subsequently are shown to have a genetic cause for their disease, we will stop all immunosuppression and work towards kidney sparing medications like ACE inhibitors or ARBs. In decreasing the proteinuria, we hope to prolong the time it takes for them to progress to ESRD or end-stage renal disease. But in these children, in families, we do let them know that this is inevitable and we have to start making the appropriate plans going forward. So we've taken a bit of a walk through idiopathic nephrotic syndrome. We've looked a little bit at the genetic forms, a little bit at FSGS, I think largely at minimal change disease. We've talked about how we approach them from a treatment standpoint, again, focusing mainly on those who have relatively clear-cut disease, and our approaches should steroids not work properly. But what's also important to keep in mind is that these children will have complications and sequelae of nephrotic syndrome that must be kept in mind, including edema, infection, thromboembolism, acute kidney injury, and dyslipidemia. And what should we do about each of those things? So I won't bore you very much with physiology here, but when we think about edema formation in nephrotic syndrome, it's important for us to consider two different hypotheses, and I will not tell you which one that I support, but overfill hypothesis is this idea that there is a primary problem with sodium during a nephrotic syndrome relapse or initial presentation, and thus there is retention of water and then eventual edema formation as a result of that. The underfill hypothesis is more related to the concept that secondary to low intravascular oncotic pressure, children have interstitial edema, and there is subsequent signaling via aldosterone to increase sodium reabsorption from the urine and thus water. So what do we do in the situation where we have children presenting with nephrotic syndrome? Is often you'll hear us talk about obtaining urinary electrolytes. And the reason we do that is because we are looking to see the degree or the relationship between the excretion of sodium and potassium. As we know, aldosterone signaling will cause an increase in the absorption of sodium, so low urine sodium, at the expense of potassium. So we tend to see an increase in the urinary potassium. That will allow us to decide, should this patient, or should they need, or clinically, could we provide them with some intravascular support in the form of albumin and then subsequent diuresis. And depending on who you talk with, a lot of people say it's kind of silly to give somebody volume and then give them furosemide, but in our experience, it works very well with the children who have nephrotic syndrome. And from a pathophysiology standpoint, it makes sense. Next is the consideration of infection. So I talked a little bit about how these children will present to hospital with nephrotic syndrome following an infection, but what I didn't talk about is their propensity for developing an infection once they are nephrotic, especially once they've been treated with immune suppression. So infection is a leading cause of morbidity and mortality in children with nephrotic syndrome. And you can see on the right panel, there are several different organisms that cause infection. This is thought to be multifactorial, related to loss of immune globulins in the urine because of the nephrosis, as well as being subjected to immune suppressing therapy. So what do we do for these children? What's important is we counsel the families on warning signs and what to look for if there's an infection, and we ensure that our patients are up to date with their immunizations. In the literature, there is no strong evidence for prophylactic antibiotics, except in the case of recurrent spontaneous bacterial peritonitis. Considering venous thromboembolism as a risk factor, these children are losing not only immune globulins and albumin in their urine, but they also lose antithrombin 3. And the nephrotic state is associated with abnormalities in platelet aggregation. And these children can be susceptible to very large clots. Now, importantly, again, the literature does not support prophylaxis. However, if there will be an indwelling catheter, such as a central line or even a PICC line during the acute stages of nephrosis, we would err on the side of contacting our hematology colleagues to discuss thromboprophylaxis. Acute kidney injury is an important consideration, and this is second to third spacing because of low oncotic pressure. And a study from Rialt in 2015 showed approximately 60% of children admitted with nephrotic syndrome, the N was 336, had evidence of creatinine elevation. And what's important to consider, low oncotic pressure, we also provide diuretics, and we also worry about concomitant infection. And all of these things can exacerbate acute kidney injury. So what do we do is we're very cautious. We obtain urine electrolytes to check the degree of intravascular filling, and we're very cautious with our Lasix, and usually we'll be providing some form of volume support. Lastly is the consideration of dyslipidemia. I mentioned before that it seems cholesterol is an innocent bystander, but actually there are concerns in children who have chronic relapsing nephrotic syndrome that it confers long-term cardiovascular risk. And the reason for this is the dyslipidemia itself is because of abnormalities in lipid metabolism. Albumin is lost in the urine, and there is an increase in free cholesterol. And also, proteins that are involved in triglyceride metabolism are sort of vamped up in their production in the setting in the nephrotic state. So what we do is we try our best to get children out of the nephrotic state in order to lower their cholesterol. But we have had some situations where children are stably nephrotic and we are unable to get them into a full remission. And in those situations, we've actually provided statin therapy. So I'm going to return back to the very first slide with a couple additions here. Again, if any of the residents on the call or medical students have had any teaching by me, they know I go stepwise. Proteinuria is the result of the podocytopathy I mentioned at the beginning of the talk. The podocytes are effaced, the albumin is lost. The proteinuria, we also have to keep in mind the immune globulins, antithrombin 3, and the albumin. With hypoalbuminemia, we see this increase in our cholesterol. We have a decrease in oncotic pressure, which can result in oliguria and subsequent AKI, and the edema phenotype, which is the interstitial edema. Edema itself is difficult for children, particularly when it is severe. It can cause significant pain. So this was I think a brief summary of pediatric nephrotic syndrome. The landscape is shifting under our feet. There are many, many new studies coming out that are pointing us in a variety of different directions. One of the big goals, I think, in pediatric nephrotic syndrome is looking at the etiology of minimal change disease, characterization of genetic forms of nephrotic syndrome. And I didn't have time to talk about this, but there seem to be a very small subset of genetic forms of nephrotic syndrome that do respond to immunosuppression. And that doesn't necessarily make much sense. So further studies are aimed at characterizing this response. New treatment modalities, as well as investigating differential responses to current therapeutics. When we go to international conferences and speak with our colleagues, we hear often that subgroups of children from different parts of the world will respond very well to, say, mycophenolate mofetil, whereas in other places in the world, they'll say they have no response. Again, likely related to this environmental as well as gene relationship. but it's important for us to understand which children will respond best to these medications. And something that's near and dear to my heart going forward are looking at biomarkers of podocyte inflammation. So if we think about these normal appearing podocyte foot processes, they undergo some type of injury, which is apparently a shock of a lightning bolt, but it's not probably. And they have subsequent effacement of these foot processes. Again, we saw this picture earlier, and I had described in the setting of effacement, we have massive proteinuria and the subsequent development of the clinical phenotype nephrotic syndrome. So what happens when these podocytes are effaced, and can we study what is happening at the level of the membrane of these podocyte foot processes? And the answer is yes. We can take a look at something called extracellular vesicles, which are in some instances actively secreted from cells. I'm going to zoom in on the microparticle piece here. Now, these are the particles of interest for myself in my research career because they are actively packaged and released from the cell of interest in times of injury, inflammation, or distress. And the membrane characteristics of each of the microparticles is similar to that of the parent cell. So if we take one step back here and we look, if we assume that these effaced podocytes are experiencing inflammation, injury, or distress and are secreting microparticles actively, if we can collect podocyte-specific microparticles, we can study the membrane characteristics at the level of the podocyte by a simple urine study. The microparticles themselves have already been shown to be important in identifying prealbuminuric diabetic glomerular injury. As well, in a study by Litvin, they were able to show that there is a difference in podocyte-specific microparticles in patients with type 1 diabetes. Again, we know that there could be early alterations or injury at the level of the podocyte, causing the release of microparticles. But in our case, we are interested in studying whether nephrotic syndrome may have some evidence of low-level inflammation at all times, and thus, during relapses, we would expect an increase in microparticles. And then we can subsequently study those to see exactly what is on them, and therefore what is on the podocyte cell at the level of the kidney. So we currently have an REB-approved prospective study that has been recruiting now for over a year and a half. Unfortunately, it was majorly interrupted by COVID, as many other people's research projects have been. We're looking at idiopathic nephrotic syndrome, and we recruit children from our clinic visits. We obtain urine samples, and we go to the lab. I go to the lab, and we obtain microparticles, which we are currently studying, and we try to pair that back with clinical data to get a better understanding of what's happening in these patients. And our hypothesis is that these urinary podocyte-derived microparticles will be robust biomarkers, of podocyte injury in childhood NS. Very quickly, and again, you'll see based on our N of 5, we've recruited over 40 patients into the study, but COVID interrupted the analysis in the laboratory. So we were only able to analyze approximately 35 samples taken from 5 children. The characteristics in this small cohort show us that there are no major differences in their age as well as in their kidney function. We noticed that those who had nephrotic range proteinuria were shown to have a lower serum albumin, which makes sense. We also noted differences in blood pressure. Now, these are absolute values, but we have further data suggesting that there are significant differences in blood pressure between those patients who have relapsing or nephrotic syndrome at the time and those who do not. When we actually look at some of the data, again, small numbers, so we have to take this with a grain of salt, and that's a very wide confidence interval. But we seem to see that there is a signal. On the x-axis, we have increasing urine protein to creatinine ratio, and on the y-axis, we have podocyte microparticles. Again, looking at here, there are a significant number of them in these samples. And this was using specific gating on flow cytometry to ensure we had podocyte microparticles and no other types of microparticles. But we tend to see a significant trend towards an increasing number of microparticles in the urine in those patients who have proteinuria. Looking at this a different way, we can see here that those patients who did not have proteinuria tended to have lower microparticles in their urine. This is quite scattered, but the actual median when comparing the two groups was significantly higher in those patients with proteinuria. But I think it's important to mention, and I think it's clear to the viewer, that potentially there are different populations here, and we have to keep this in mind going forward. And that's also, important to consider here as well. Again, we have very small numbers, but when we attempted to do ROC analysis with area under the curve, we had quite good classification when we set nephrotic range proteinuria and we looked at podocyte microparticles. On the left, you'll see the true positive rate, and on the x-axis, you'll see the false positive rate. We hope for a very impressive classification that we would have a box that follows my cursor, suggesting that you can have, at a very low false positive rate, a very high true positive rate. However, given our small numbers, I still think that this is quite good classification when looking at whether or not nephrotic range proteinuria can be, in a sense, classified by the podocyte microparticle level. So what about the blood pressure and heart rate findings that I mentioned before? So unfortunately, I'm going to tell you that you have to come to CHIO Resident Research Day in a couple weeks, where I will be discussing this in full. I won't give you any more at this point. So in summary, why do we do these things? We do them so that we can help benefit the children and their families in our practice. This is the same young boy in this photograph that I showed you at the very beginning of the talk. He was treated appropriately, and we can see quite a significant improvement in the edema. What's important going forward from a clinical standpoint and a research standpoint is keeping in mind and understanding that nephrotic syndrome is a podocytopathy. So our investigations, our treatments, then future research will be dedicated and directed towards looking at podocytes. Minimal change disease is the most common form in pediatrics, and that allows us in most instances to initiate therapy almost right away without biopsying all of the children presenting. Steroids are the gold standard of therapy. The trouble is these children are exposed to enormous cumulative steroid doses, and there are several untoward effects that we try our best to stay away from. So we need to further arm ourselves with other medications aside from steroids, which is a big area of research at this point. Newer avenues of research, and something that I will be carrying on in the years to come, is looking at low-level podocyte inflammation and microparticles, among other things. I want to say thank you very much to people who have been involved. So Drs. Janusz Feber and Pavel Geyer in the department or division of nephrology, Dylan Berger, who will be my upcoming PhD supervisor, and Fengsha Zhao, who did flow cytometry on these samples. And we had some methodology and statistical analysis input from Anne Sampelliaros and Richard Webster at the Research Institute. And I did mention earlier that we obtained urine samples in the clinic. So I would be crazy without saying thank you to both Paula and Anne, who helped me so much in the collection of urine in this study, as well as reminding me when we were having nephrotic patients in the clinic. And with that, I'll stop, and I'm happy to take any questions at this time. So thank you very much.
Thank you very much, Rob. That was a very nice overview, and maybe you could just answer a couple of small things for me. In part of your workup and patients who present with a straightforward minimal change disease, or at least presumed minimum, at what point do you go to further investigations such as say anti-nuclear antibody testing, quantitative immunoglobulins? And at what point would you consider biopsy?
That's a great question. I think if we look in different textbooks or in the literature, you might get slightly different answers. What I've seen most often is when we have the classic presentation, so the age range, the presentation of nephrotic range proteinuria with the classic edema, and no history of hematuria, meaning gross hematuria, joint involvement, rash, hemoptysis, epistaxis. If there aren't some of these overarching signs and symptoms on presentation, we often wouldn't go much further. Again, it depends, I think, on practice preference across Canada and the world. Some people will argue that on first presentation, we should always obtain complement. I think that's a common practice. When it comes to looking further at ANA, I think it would be most related or most tied back to the symptoms and signs of presentation. When we have somebody presenting with, for example, nephrotic range proteinuria that was preceded by gross hematuria, in almost all instances, those children would undergo biopsy because we wouldn't be exactly certain what was the pathomechanism of their nephrotic syndrome. We also know that there are different patient populations who will have nephritis, IgA nephritis, or post-strep glomerulonephritis, in fact, who can have very poor outcomes, very poor courses, and can go on to develop nephrotic syndrome. And those children would be on our radar for further investigations to make sure we weren't missing something. Kind of a difficult question to answer. I understand what you're asking, but I think it can be quite variable. But
okay. Great, thank you. Other questions or comments for Rob? I don't see any blue hands or anything in the chat. We still have lots of time. So Dr. Sisto, have you looked into what causes hyperlipidemia in the resistant cases?
I think it goes back to the mechanism most observed related to the low albumin. Low albumin itself is driving the cholesterol to be elevated simply because there is more free cholesterol. But also I believe the liver is undergoing some changes in an effort to increase lipoproteins that are lost in the urine. And there's, I believe, subsequent signaling that leads to these elevations in triglycerides, that leads to these elevations in cholesterol. Now, interestingly, there are some studies, there are a very small number of patients that have looked at markers in lipid metabolism and also in things like ghrelin and leptin, suggesting there might be some aberrant signaling in these pathways, which could then go on to subsequently cause increases in lipid metabolizing proteins or in lipids themselves. And I think in some instances, it could be related to the patient prior to their development of nephrotic syndrome if they have concomitant risk factors, poor diet, inactive lifestyle. So it's a big multifactorial problem. If you're asking specifically about it's hyperlipidemia. I just pulled up the question again. So yeah, I think that would be an easier way to summarize it. I see a subsequent follow-up question.
Yeah, so slower motility of the bowel and higher cholesterol. What about that?
So I haven't come across that specifically in my reading when I consider nephrotic syndrome. I can understand that in these patients, if they have interstitial edema, they may also have evidence of ascites, and they may also have bowel wall edema. I am trying to think anecdotally in our clinic. I think everybody has constipation in our clinic, to be honest, but I can't think anecdotally if these patients have a specific propensity for constipation, say suggesting lower or slower motility of the bowel. So I don't think I can comment on that.
Okay, Karen?
Yes, good morning, and thank you, Rob, for that very interesting presentation. I had a question to do with your podocyte microparticle evaluation in the urine, and if you feel that this might be something that could potentially be applied to, say, our lupus population who have renal involvement and perhaps features of nephrotic syndrome.
That's a great question. Thank you very much. Yes, the short answer is yes. So this is right now being developed in our small patient population, looking at this sort of idiopathic nephrotic syndrome. But I feel going forward, this could be applied in many, many instances because we have the ability to use this targeted flow cytometry, which allows us to say we want to pull only podocyte microparticles out of the urine, or only tubular, or anywhere that we can find a marker. So you're absolutely right. In the setting of lupus, we have different grades of lupus, and we can look. We even have these patients who develop nephrotic syndrome as a result of their lupus. So we certainly could apply this in patients with lupus, looking at their podocytes, again at the membrane characteristics of the podocyte. Definitely.
Perfect. Thank you so much.
Other questions or comments for Rob? I don't see no hands up, nothing else in the chat. So we'll draw it to a close a little early, which gives people a little bit more time. Thank you very much for your excellent presentation, Rob. We look forward to seeing how things evolve with your research, and certainly look forward to Research Day, learning a little bit more about your work. Thank you very much.